group of drugs which facilitate the relaxation, voluntary control over the muscle, right? So you must have seen the general anesthetics and the doctors in the operation theater using general anesthetics. So to basically facilitate that general anesthetic procedure, skeletal muscle relaxants are used. Basically, to facilitate the voluntary muscle contraction and to aid into general anesthesia. Okay. So these are basically uh, divided into peripherally acting, centrally acting, and directly acting. So we'll be dealing more about the peripherally acting drugs, which are a group of drugs which would act on the neuromuscular junction. Okay. So uh, firstly, a brief about the history. These agents were initially earlier known as the arrow poison in the 15th century. You must have seen various movies where the soldier uses uh, the string and bow, and on the bow, I mean, sorry, on the arrow, on the spear of the arrow, they would you know, have that poison and which would go and strike the enemy, and the enemy would stop moving and would later on die. So the first incident was reported by an English statesman, Walter Raleigh, in 16th century. He coined the term orari. Okay. Next, Brodie and Waterton. These were scientists in the late 18th century, the late 19th century, sorry. These demonstrated uh, that basically after purification of the animal, if the animal was still given the artificial respiration, the animal would survive. In a way, pointing that the mechanism of action of curare-like drugs would inhibit the respiratory tract and subsequently lead to apnea. But where if you give the artificial respiration to the animal, they would survive. Later on, Claude Bernard demonstrated. I will be discussing a brief about it in the subsequent slides. So this is, you must have seen in various movies or cartoons, the ancient American tribal population. Even in the present times, I would say there are certain tribal populations in various parts of the globe where they still don't have the access to the modern facilities. So they still maybe use these methods. So the ancient Americans, they used to have this uh, arrow gun, which they used to have the small arrows, and they would blow the pipe, and through that pipe, the arrows which had the muscle relaxants would go and hit the target. In this case, this pig you can see, this has an arrow on it. So, and the pig is lying on the ground. That means the pig is not able to move. So these were the ancient, the earlier use of curare-like drugs, which were later demonstrated by various physicians, various anesthetists, and were put to use. So the source of the curare was mostly Strychnos toxifera, which is an ancient plant that used to be most of the curare used to be extracted from Strychnos toxifera. Now, Claude Bernard's experiment. Basically, Claude Bernard demonstrated with the use of his frog experiments that the site of action of the curare-like drugs is the neuromuscular junction or the perijunctional area. He would demonstrate uh, he in his experiments basically instilled the needle of filled with curare-like drugs and would instill in frog. Initially, he reported that the frog was jumping, and after a few moments, uh, after a few minutes, the frog didn't contract or didn't jump, and the frog became placid. Now, coming to the topic of skeletal muscle relaxants, but before that, a very brief mechanism of ACH release, which you would have read in your previous classes. That ACH is consolidated into the empty vesicle by the help of ACH carrier. It is fused with the axonal membrane. There is a release of ACH, which subsequently is acted upon by the ACHE, which is the acetylcholine esterases, which break the acetylcholine into choline and acetate for reuptake into the axonal membranes. Okay. This is in gross what you need to remember as of now for the understanding of this concept. So what happens is ACH is acted upon at the neuromuscular junction. We from our earlier classes on the cholinergic system, we have understood that there are two types of cholinergic receptors, that is the muscarinic receptors and the nicotinic receptors. In this case, in case of skeletal muscle relaxants, we have all known that the skeletal muscle relaxant act on the neuromuscular, that is the NM receptor subtypes of the cholinergic receptor. In this case, we would be talking more about the NM receptors, that is the receptors, cholinergic receptors present on the neuromuscular junction. Okay. So there are two types of drugs which we would be discussing today: the depolarizing and the non-depolarizing drugs, and how they bring about the skeletal muscle relaxation. We'll be discussing. So just to keep in mind, just remember the small diagram, and uh, this will facilitate your understanding of the concept. Now, this is a basically top view and a cross section view of the nicotinic ACH receptor. Okay, so you just remember that the receptor is composed of five. Basically, it is a pentameric structure composed of two alpha subunits, one beta, one delta, one gamma subunit. So what happens is when acetylcholine comes and binds to these receptor sites, which have been pointed with the use of these arrows, you would see that acetylcholine comes and binds. What happens is there is a configuration change. There is a configuration change of these receptors, receptor monomers, basically. So each of this would realign, would readjust, and subsequently that would help the permeation of the sodium ions from the outside to the inside of the membranes, right? So more of sodium is present on the outside as compared to the inside. Sodium would then enter into the membrane. Thereby, it would depolarize. Thereby, it would, when the inside of the membrane becomes more positive, it becomes depolarized and subsequent conduction occurs. Now, to understand a brief about how the mechanism occurs. Basically, what happens is before an action potential, firstly, if an axon conducts an impulse, so the propagation of the action potential leads to uh, fusion priming, docking, priming, fusion, exocytosis of the synaptic vesicle. So basically, when an excitatory impulse would come from the neuron, it would help in docking, priming, fusion of these synaptic vesicles. Now, to understand this, just pay attention to the square diagram on the upper right hand side. Here we can see that there are few names given which you might not be familiar with as of now. I'll try and explain. What happens is when the fusion occurs, so how the fusion is facilitated, the snap proteins or the snare proteins, which are present at the axonal membranes, these would help in binding of the syntaxin, which is the yellow colored part, with the MUNC18. This would bind with these axonal and the vesicular proteins. These would in turn help the formation of calcium inside. These would help in opening the calcium channels, which are the yellow colored. More calcium would be going from the outside into the inside of the cells. These calcium, the calcium which has entered into the axon, would help in binding this complex of the neuronal and the membrane, vesicular and the membranal tissues, vesicle and the membranal proteins. It will help and bind the calcium. Again, at the end, it would go on to bind at the synaptosegment. This happens at this end also. So what happens is subsequently when the proteins bind together, there is a exocytosis. There is a pulling of the membranal tissue with the vesicular tissue, and as a result, the neurotransmitters are expelled out, which subsequently uh, bind to the neurotransmitter binding site on the next neuron, thereby facilitating the inflow of sodium ion and the propagation of the impulse. So when an action potential comes through the excitatory, so through the axons, the excitatory input, it would lead to a generation of EPSP. EPSP is nothing but excitatory post-synaptic potential. This is just to familiarize you with the concept. If you don't want to remember this much detail, it is good. But just to make the concept more clear, I have tried and incorporated this diagram into the slides so as to facilitate. If you are not able to remember, it's okay. So an EPSP is generated, which is excitatory post-synaptic potential. And if this EPSP crosses the threshold value, an action potential is generated, and which subsequently passes on to the next neuron. Similarly, when an inhibitory input comes, the opening of chloride ion channels is facilitated. Okay, so in some cases, when the input is excitatory, the sodium ion inflow would be there. In some cases, where the input is inhibitory, chloride ion channels would open. For example, the benzodiazepines chloride ion channel, the chlorine inflow would occur, and what happens is there is uh, hyperpolarization of the next membrane or the next neuron. So accumulation of the excitatory input and the inhibitory input basically determines what kind of response, whether it would be the next neuron would be excited or the next neuron would be inhibited. That is how it determines the transmission of impulse. Now a brief about the nicotinic transmission at the neuromuscular junction. As we have already talked about, expulsion of ACH through the axonal membrane, binding of the ACH at the nicotinic receptor sites, sodium which lies on the exterior. After ACH binds to the site, sodium goes into the cell, and there is an EPSP or an excitatory post-synaptic potential which is generated. And if that is cumulative, if that excitatory potential is seen in many neurons of the nerve, then the excitation or the action potential is generated, and subsequently the impulse is passed on to the muscle, and there is a contraction of the muscle. So this is what is happening throughout. Now coming to the various drugs that we will be discussing in our today's class. So firstly, we have the non-depolarizing and the depolarizing blockers. These are the drugs which would act in the periphery. Okay, so how they act, we'll be just talking about. These classifications must also be given in a standard textbook. If you understand it better from there, no problem. But I'll just try and tell you some key points that will facilitate you learning from the textbook. Okay. So the non-depolarizing blockers are the ones which simply sit at the receptor binding site. Depolarizing blockers are something which would depolarize the membrane. Longer acting non-depolarizing, you can remember the prototype drug in this class, that is the D-tubocurarine. D-tubocurarine, it is the prototype drug in non-depolarizing or the competitive blockers. Again, longer acting drugs, you can remember it by PAN. PAN means throughout. PAN, pancuronium, picuronium. Okay. Pan Am होता था ना पहले एक फ्लाइट आता था Pan Am throughout America. So Pan you can remember as long. Pipe again you can remember as long. Doxa and D-tubocurarine. These are the longer acting non-competitive competitive blockers. Intermediate ones are the rocuronium, vecuronium, rapacuronium, atracurium and cisatracurium. Shorter acting include the use of mevacurium, ultra. Just need to remember, if you don't even remember all the names, that's perfectly fine. But just remember, try and remember the prototype drugs. Okay. The depolarizing includes the use of succinylcholine and decamethasone. Now, a brief about the structure-activity relationship. So, the depolarizing muscle, firstly, we'll be discussing about the depolarizing neuromuscular blockers. Initially, decamethonium was used. What is decamethonium now? It is a structure where between the two quaternary nitrogen atoms, we have 10 carbon chains. Between the two quaternary nitrogen, if you were to look at the top end of the side, you would find the molecular structure of decamethonium. You would see between the two quaternary nitrogen uh, we have 10 carbon chains. So more the number of carbon uh, in between the two quaternary nitrogen, more is the potency. More strongly it binds with the receptor site, and similarly, if it binds more strongly to the receptor site, more chances of side effect profile. Hence, decamethonium is not used nowadays. Decamethonium is not used nowadays, but for historical importance and to understand the structure, we have mentioned it in our slide. Now, similarly, we have the acetylcholine. This is the molecular structure of acetylcholine. So, to understand succinylcholine, which is a prototype of a depolarizing neuromuscular blocker, succinylcholine is nothing but two molecules of acetylcholine combined together. Right? Now, a brief about the steroidal compound. Why it is important? As and when you will go through your textbook after the discussion, you will understand that steroidal compounds are the ones which have the steroidal as the skeletal. But basically, this is the skeleton of these compounds, and permutation combinations at various R positions leads to development of various steroidal neuromuscular blockers. The important ones are pancuronium, vecuronium, rocuronium, rapacuronium, and picuronium. Okay, so these are the steroidal compounds. Why these are important? I will be talking in the subsequent slides. But just remember, these are the derivatives of curare-like drugs. But because of the steroidal structure, we basically tend and intend to minimize the side effects, minimize the complications, and uh, do not alter the potency or efficacy of the drug. These are the steroidal compounds. Now, mechanism of few slides, we'll try and understand how depolarizing and non-depolarizing blocker acts. So to understand, this is a very basic diagram. This is a very basic diagram of neuromuscular junction. This shows the membrane. This shows the channel. The one and the bluish color shows the channel. This is a membrane. So we can see here in the above diagram that whenever an agonist binds to the receptor site, in this case the agonist is acetylcholine, the receptor site is NM junction, NM receptor, sorry. So whenever an agonist binds to the receptor site, it would facilitate the opening of the that to a certain extent sodium would fall. To a certain extent the sodium would uh, move from the outside of the cell to the inside. Similarly, this is a basic physiology. But now in this case, whenever we are using a non-depolarizing blocker or a depolarizing blocker, what happens is the site of binding of the drug, the site of binding of the agonist is taken up by non-depolarizing or a depolarizing blocker. In case of non-depolarizing blocker, it simply sits there, obstructs. In a non-depolarizing blocker, what it would do is constantly keep the channel in an open, constantly keep the channel in an open state for a while. Antipolar rotation is D-tubocurarine. It, as you can see, the downward edge, the downward shape of D-tubocurarine and the acetylcholine is almost similar. So these can both compete for a binding site here, which is the nicotinic receptor at the neuromuscular junction. Whenever D-tubocurarine comes and sits at the neuromuscular junction, what happens is it would inhibit the channel opening. The impulse would not pass. Impulse which was passing through the acetylcholine, as we remember, the EPSP was getting generated. There was a configuration change which would facilitate the inflow of the sodium ion. All those series of events would not take place. So, as depicted in this diagram, sodium is not able to enter into the cell. It is just passing from the outside. So, whenever there is no entry into the cell, the inside of the there is no depolarization in the uh, cell and no propagation of the impulse takes place. In case of a depolarizing agent, for example, succinylcholine, that here what happens is succinylcholine from our previous discussion, we remember that it is nothing but two molecules of acetylcholine bound together. Almost similar in action to acetylcholine, but due to there is a bit of change, but it can be compared to acetylcholine. So now what happens is the receptor sites recognize succinylcholine. The receptor site recognize succinylcholine. In the previous discussion, previous example, we knew in the non-depolarizing blockers that it would not just recognize, the shape remains similar, but it would not recognize D-tubocurarine. In this case, the receptor recognize succinylcholine would cause persistent depolarization. Depolarization. Now you would ask why persistent depolarization? Because these succinylcholine, although have similar effect as compared to acetylcholine, but whenever they are bound at the receptor site, these are not degenerated with the acetylcholine esterases. Conventional acetylcholine esterases, which would degenerate ACH, do not degenerate succinylcholine. Okay, so since these are present, there is persistent opening of the sodium channel and the depolarization continuously takes place. That is a depolarizing phase one. So how would it manifest? It would produce transient fasciculation followed by flaccid paralysis. The mechanism for this transient fasciculation is whenever the inside of the cell is depolarized, the calcium is released from the sarcoplasmic reticulum. Whenever the inside of the cell is depolarized, the calcium would be releasing from the sarcoplasmic reticulum, binds to the calcium calmodulin, forms the calcium calmodulin complex, would facilitate the excitation contraction of the muscle. This produces initial fasciculation or twitching. And since the sodium channels are open for a longer duration of time, there is persistent depolarization which is happening, and initially which would be manifested as fasciculations and followed by flaccid paralysis. Why? Because irrespective of the repolarization status of the membrane, the calcium just uh, moves inside the sarcoplasmic reticulum in a time-dependent manner. So, which manifests initially as fasciculation followed by flaccid paralysis. Now, understanding about the phase 2 block. So, here what happens is due to the continuous presence of succinyl choline at the receptor site, there is a constant stimulation. And since it is present at the site for a longer duration, so physiologically, we would, from our earlier discussions of G pharmacology, we know that there is a desensitization of receptors. You must have all come across the term like desensitization of receptors. So what happens is the GPCR, this is the G protein coupled receptors, they get and bind to the blockers, which is beta arrestin in this case. Beta arrestin in this case, which would hamper the G protein mediated CMP pathway, and the receptor, despite being in the presence of agonist, which is succinylcholine in this case, would not be able to bring about a response. Although the membrane is repolarized and ready to be depolarized again, the receptors are desensitized. This is known as phase 2 block. Okay, so phase 1 block and phase 2 block. Now, coming to the discussion about the sodium channels. Firstly, we know that the sodium channels exist in three stages, that is the resting state, active state, inactive state. So, in the resting state, if you can see on the slides, there are two gates that are shown in the diagram. Firstly, a gray colored one, which is the voltage gated. The red colored one is the time gated part of the voltage gated sodium channel. So basically, we can see that is this is the resting state. Resting state is the one which precedes the activity. In this case, the time dependent gate is open. The time dependent gate is open. The voltage dependent gate is still closed. Whenever a depolarization comes and the surrounding membrane of this voltage gated channel, surrounding membrane of this tissue of this voltage gated channel gets depolarized, automatically this voltage gated channel opens, as is seen in this diagram. The active state, the because the time dependent gate was already open, voltage whenever the voltage gated sodium channels, whenever there is depolarization, they would automatically open the voltage dependent gate of the sodium channel. Lastly, in the inactive state, when the potential decreases and whenever the impulse is propagated, it has passed on. What happens is, in a time-dependent manner, these time-dependent gates of the sodium channel automatically close, and subsequently, to get ready for the next impulse to come, these time-dependent channels automatically come to the resting state where these would open, and whenever the next action potential comes, these voltage gates would automatically open and would uh, facilitate the inflow of the sodium ion. Now, a brief about the actions of the various drugs, that is the depolarizing blockers and the non-depolarizing blockers. So, depolarizing blockers, the prototype we have is succinylcholine. Non-depolarizing, the prototype we have is D-tubercular. So we try and discuss various actions under these two headings, these two drugs. But whenever we so the newer congeners which are developed on these lines only would have similar actions as compared to these drugs, but with a few favorable or unfavorable changes. But mostly due to owing to its action, owing to its structure, the action would remain the same. So in case of skeletal muscles, there is initial fasciculation followed by flaccid paralysis. ठीक है, इतना चीज समझ में आ गई. पोस्ट ऑपरेटिव माइल्जिया, बाय इसमें क्या होगा? Initially fasciculation. Why? Because there is constant depolarization in the sense of succinyl choline till the time it is automatically degenerated or degraded. It will cause fasciculation. अगर flaccid paralysis का मतलब there is no tone, there is very much reduced tone in the muscle. Post of myalgia, because there is more expulsion of the leaky potassium channels due to constant depolarization, it will cause post-operative myalgia. In this case, because there is no fasciculation, there is just primarily weakness, flaccid paralysis. Flaccid paralysis because there is no depolarization response and weakness. In uh, depolarizing blockers, autonomic ganglia is stimulated. As we know that it has the potential to stimulate. So whenever there be nicotinic receptors, be it ganglia, be it neuromuscular junction, these cause stimulation. It has a propensity to cause stimulation. It might or might not, that is different thing. It has a propensity to cause stimulation. Whereas in non-depolarizing agents, there is just no stimulation. The drug just binds and sits on the receptor side, and thereby the subsequent events don't happen. So, but in the newer derivatives, that is the one, that is the steroidal agent that we talked about earlier. For example, the bipyronium, becuronium, procuronium, pancuronium that we talked about. These agents are devoid of this autonomic ganglion blocking effect, hence are nowadays preferred because of the no action on autonomic ganglia. Histamine release. I would say in both the cases, depolarizing and non-depolarizing agents, I could not find a convincing answer. Both of these, to a certain extent, cause histamine release. CVS, depolarizing blockers in lower doses, what they do is they stimulate the parasympathetic ganglia, and which would lead to bradycardia, which is the case in low doses. But in higher doses, it causes tachycardia. Tachycardia primarily has two reasons. Firstly, it could also be due to excessive calcium expulsion from the inside of the cell, which leads to hyperkalemia, which leads to tachycardia, or at a higher dose, it has a propensity to stimulate the sympathetic ganglia also, which would cause tachycardia. The non-depolarizing blockers, basically, it just blocks the parasympathetic ganglia and would cause tachycardia and subsequently hypotension. So coming on to the pharmacokinetics, mostly being the quaternary compounds, these are mostly inactive orally, are active primarily by the IV route or intramuscular in some cases, do not cross the blood-brain barrier owing to its quaternary structure. Termination of effects mostly in these cases is rapid redistribution. Rapid redistribution from the site of action, there is redistribution and there is termination of effects. But this is true in case of small doses only. In case the doses are increased, the tissues become saturated, the termination of effects take longer time. Elimination mostly are eliminated by the kidney. Drugs, sevoflurane, these are eliminated by pseudocholinesterases or butyryl cholinesterases. And as we had discussed that succinyl choline, although similar in appearance to acetylcholine, is not exactly acetylcholine. So the succinyl choline degeneration occurs with the help of pseudocholinesterases or butyryl cholinesterases. And there is another term which is known as spontaneous degeneration. Spontaneous degeneration in case of atracurium and cisatracurium, which is known as Hoffman's elimination. Hoffman's elimination. Please remember this. This is important for your MCQs also as well as for your vivas. Hoffman's elimination is shown by cisatracurium and atracurium. Here, the drugs are themselves converted into some alkene derivatives. Alkenes which are unstable and these are automatically spontaneously degenerated. Atracurium and cisatracurium. And since these mark this next point also, and since these are spontaneously degenerated, these drugs do not require liver or kidney for its elimination or excretion. Hence, these drugs are preferred in patients with renal failure. These drugs are preferred in patients with renal failure since they are themselves metabolized in the plasma and are themselves degenerated. These do not either preferred in case of renal failure. And the drugs which are metabolized by the liver include bacteria. The salient features I'll just talk about. Uh, the red line in the diagram, we have mentioned a lot about the various drugs. The red dot that you can see on the red box that you can see on the screen is basically time to maximum blockade. Time to maximum blockade, and the yellowish part shows time to recovery. Time to maximum blockade and time to recovery. Okay, so we can see in case of Mevacurium that the time to onset is approximately 2 minutes and time to recovery is 16 minutes. So basically, it is a shorter active derivative. Within a span of 16 minutes, the effect of this skeletal muscle relaxant has gone off. So, uh, making it ideal for short surgical procedures, whereas in case of cisatracurium, we can see that the duration of action or time to recovery is considerably more. So it can be used in certain procedures where a longer duration of skeletal muscle relaxation is advised. For example, mechanical ventilation in critically ill patients. And also the added advantage of cisatracurium atracurium is spontaneous degeneration, Hoffman's elimination, and so are also preferred in the patients with renal failure. In case of deep levocurare, the prototype drug of non-depolarizing blockers, these have a propensity to release histamine. These have a propensity to release histamine, and these also have a propensity to cause ganglion loss. Propensity to release histamine, propensity to cause ganglion blockade. Hence, not preferred nowadays. Hence, not preferred nowadays. The release of histamine could cause hypotension, release of histamine could cause bronchoconstriction and various other side effects. And autonomic, the blockade of ganglion also comes with its own side effects, hence not preferred nowadays. Newer derivatives are preferred. Newer derivatives like rocuronium, vecuronium, pipecuronium, pancuronium. As we can see in case of rocuronium, it is rapidly acting. Action occurs within a span of 1 minute. The action occurs within a span of 1 minute, quickly acting. Whereas in case vecuronium, pipecuronium similarly are the drug which would have the onset fairly quickly, but are the pipecuronium in particular, pancuronium, these are longer acting agents, so can be used in cases where desirable amount of skeletal muscle relaxation is the time is, so it can be used in those cases. Another disadvantage of the use of pancuronium is its vagolytic effect. Its vagolytic effect. Vagolytic means it would inhibit the M2 receptors in the heart and would lead to tachycardia. Hence, it is also a problem with this group of drugs. And in case of depolarizing drugs, for example, succinylcholine, problems include firstly advantages that it is a very shorter acting drug. The time to onset is very short, and the time to recovery is also very short. Problem lies in its propensity to cause hyperkalemia. Hyperkalemia can cause tachycardia and other sequelae of events, post-operative pain, okay, and it might also lead to malignant hyperthermia. We'll talk about what malignant hyperthermia is in our subsequent slides. But please remember malignant hyperthermia with the use of succinylcholine. Okay? So apnea and respiratory paralysis क्यों हो रही है? Because we know that apnea in cases of atypical pseudocholinesterases, in cases of drugs with atypical pseudocholinesterases, the mechanism of action of succinylcholine, the time duration of action of succinylcholine, which was supposedly about 2 to 5 minutes, is now exceeded to up to 1 hour. Why? Because we know that these drugs are skeletal muscle relaxants. And considering a person has atypical pseudocholinesterase, that is pseudocholinesterase which is not able to metabolize succinylcholine, succinylcholine would be present at the receptor sites for a considerably long time. This is a genetically most cases the apnea and respiratory paralysis would exceed its time duration to approximately 1 hour. Pseudocholinesterase. Increased potassium efflux in patients with the predisposing conditions might exacerbate the hyperkalemia. Hypotension and CVS collapse. Hypotension and CVS collapse. Because it would stimulate the parasympathetic ganglion at a lower dose, there is the potential to cause hypotension and bradycardia. Malignant hyperthermia. Malignant hyperthermia. Again, malignant hyperthermia is again a genetically predisposed condition where in patients with atypical receptors, where more calcium is released from these receptors, these cells, more and more calcium is being released, and which causes contraction of the muscles. And due to continuous contraction, there is a rise of body temperature, which is approximately in the tune of 1 degree every 5 to 6 minutes. So it is also a very harmful condition. Electrolyte imbalances also occur. So in a few genetically predisposed individuals, use of these drugs might lead to malignant hyperthermia. Please remember malignant hyperthermia, especially when given along with halothane, which is a general anesthetic. Decreased tone and motility of the GI tract, sinus bradycardia, which occurs with succinylcholine, and post-operative myalgia with the use of these drugs owing to its electrolyte imbalances, allergies, and anaphylaxis. Now coming to a brief about drug interactions. Cholinesterase inhibitor, these enhance the depolarizing blockers. Why? Because cholinesterase inhibitors, they would uh, inhibit the degradation of acetylcholine. Inhibiting the degradation of acetylcholine makes it available at the receptor site for a longer duration of time. And since succinylcholine is also present, acetylcholine would also be present if you give cholinesterase inhibitors. Both of these would be competing for a same receptor site, and both have the predisposition to stimulate or depolarize the cell. So cholinesterase inhibitors would enhance depolarizing and antagonize the competitive block. Okay. So coming to the combinations, synergistic combinations include the use of desflurane and isoflurane, which almost works by the same mechanism, that is inhibition of the sodium channel, independent sodium channel. The desflurane and isoflurane so would act similarly as compared to the blocker. depolarizing blockers, calcium channel blockers and diazepam. These all have a subsiding effect on the nerve muscle junction and would add synergistically to the depolarizing blockers. Antagonistic combinations include the use of calcium salts, adrenaline, and various steroids. Uses, as we have already discussed, it is used in surgical anesthesia to facilitate procedures like laryngoscopy, intubation, and in ECT of psychiatric disorders. ECT is electroconvulsive therapy in patients having acute disturbances. The benzodiazepines, acute disturbances. ECT is the modality of choice. What is ECT? You must have seen in various movies that in asylums they would put a metallic cap on the head of the patient and they would give electric current through that cap to the patient. So that is acute. In case of acute illnesses, psychiatric illnesses, that is the modality of choice. But since ECT comes with its own complication of more contraction and relaxation of the muscles, so there can be several disorders. Sorry, the sequelae can be disturbing muscle injuries or the bone fractures, etc. So succinylcholine along with benzodiazepine is used in those cases to relax the skeletal muscle in severe cases of tetanus and status epilepticus. Now coming to monitoring, how do we monitoring? How we do the monitoring of the skeletal muscle relaxation? Do not know, do not need to remember this diagram. This is just for your, you know, uh, understanding purposes. This is something which is based on anesthetic setup. So what actually happens is in the first one, if you see the train of four, I'll be just telling about the first one. Almost others are similar. You don't need to go into details about this one unless until you are interested. Train of four, you can see the first one, the evoked stimulus. It shows that on normal response, if we were to just elicit the response, these would be the response in normal scenario. If you were to give a stimulus based on the contraction and based on the stimulation of the nerve, these would be the responses. But in case of the blockers, depolarizing blockers and non-depolarizing blockers. In depolarizing blockers, we see that these are also constant but diminished. Why diminished? Because you are not giving enough time for the nerve to repolarize and again depolarize. So the response, there is no uh, complete depolarization and no complete response. So the responses also might be there, but still would not be that uh, complete. Similarly, in phase 2 block, we would see a fade. What is a fade basically? In case of a fade, there is a diminishing of the response. Why? Because as we've known that the receptors become desensitized, so even if the agonist is at the site of you know able to propagate the impulse. So even despite the presence of an agonist, the response would be diminished. So as it is seen in this diagram, a diminishing response or a fade, which is seen in phase 2 block. Non-depolarizing blockers, similar to the fade, to the phase 2 of the depolarizing blockers. Again, a fade would be seen because in the presence of a blocker, ACH cannot act, and even if you try to stimulate the muscle junction, it wouldn't be able to depolarize, equivalently giving rise to a fade. Quickly coming to the centrally acting. So this is a very basic diagram that stimulus comes, it binds to the receptor. It is a sensory neuron binding to the motor neuron to the effector side or the muscles in this group, and a response is created. This is the central mechanism of action. In the ones that we have already discussed now, the peripherally acting neuromuscular, the peripherally acting blockers, the site of action is at the this junction of the nerve and the muscle. But in this case of centrally acting, the site of action lies centrally in the, either in the association neuron or the junction of the association of the motor neuron. So, to discuss few drugs like mepinephrine group, which includes the use of chlorzoxazone, benzodiazepines with the use of diazepam, GABA derivatives, for example, baclofen, centrally acting alpha-2 agonist, for example, tizanidine. So, in case of chlorzoxazone, what happens is it stimulates the interneuron, it inhibits the propagation of this uh, impulse from the interneuron to the motor neuron. So it inhibits the propagation of pulse from the interneuron to the motor neuron in case of mepinephrine growth. Whereas in case of the rest three, I will be discussing. In the tizanidine group, the alpha 2, which is the inhibitory in nature, would inhibit the discharge of sympathetic neurotransmitters, thereby decreasing the tone of the muscle. Baclofen, what it will do, it will facilitate the GABA, the chloride ion channel. It would cause hyperpolarization. It would bind to its GABA binding site in the channel. It would facilitate the hyperpolarization of the receptors. And as we have known that EPSP, IPSP accumulation or the response additive to both would be C. So if it is a hyperpolarization response which is more, the depolarization would be considerably less and there will be relaxation. And similarly, benzodiazepines which also bind to the same site as compared to the uh, the same channel as the benzodiazepine GABA chloride channel, but at a different site would again lead to hyperpolarization of the channels of these chloride ion channels, subsequently lead to hyperpolarization, no propagation of the action potential or the impulse, subsequently depressed uh, reaction. Now coming to dantrolene is a directly acting. These were the drugs which were acting centrally. Dantrolene would act directly. It is the drug of choice for malignant hyperthermia. I had discussed malignant hyperthermia in our previous slides, where in predisposed individuals there is a release of calcium and it causes contraction of the muscles. There is a rise in body temperature and there are a lot of electrolyte imbalances. So dantrolene is a directly acting neuromuscular blocker. It would go and bind to the calcium. It would inhibit the release of calcium and would inhibit the muscle contraction and muscle heat production. So to understand it, as we have understood that whenever depolarization happens, it would facilitate the release of calcium ions from the sarcoplasmic reticulum, which would cause contraction. In the case of malignant hyperthermia, the contraction and is more and would lead to more rise in temperature. Naturally, it inhibits the ryanodine RYR receptors, expulsion of calcium into the skeletal muscle is decreased, and this is taken care of. For malignant hyperthermia, IV is usually given. IV dantrolene is the malignant hyperthermia. So to summarize, peripherally acting agents, centrally acting agents, directly acting agents. Mechanism is a competitive or a depolarization block. Centrally acting inhibits the polysynaptic reflexes as well as interneuron and sensory neuron. Directly acting reduces the depolarization induced calcium release. Route is primarily IV, oral, or parenteral. Types of paralysis, progressive placid paralysis, we've understood reduced muscle tone, but no loss of power. No loss of power in case of centrally acting drugs. In case of partial power, paralysis only happens in the peripheral acting agent, as the factor directly acting. CNS. Peripherally acting, being quaternary, mostly do not cross the blood-brain barrier. Centrally acting agents, these have a propensity to cause blood-brain barrier, and hence sedation is a classification on common side effect with the use of centrally acting agents. Directly acting, these cross the blood-brain barrier but cause a lesser degree of sedation. Uses facilitate the surgery, endotracheal intubation. Centrally acting are used in spastic conditions and status epilepticus. Dantrolene may be used in cerebral palsy, spinal cord injuries, and is a drug of choice.